My name is Savannah Denzin, and I'm going to be presenting my case study of a malignant neoplasm of the upper outer quadrant of the right female breast. A little bit of my patient's background is that she is a 58-year-old female. She's married. She has adult children. Her last menstrual period was 5 years ago. Both of her parents are deceased. She smoked a lot, in quotes, of cigarettes for 30 years, and she quit in 2004. My patient presented to her primary care physician with complaints of a lump in the right upper outer breast that appeared 3 to 4 weeks prior. She reported tenderness with pressure or significant touch, and she felt a dull ache that resolved when the touch was removed. No skin changes were present at the time. The patient had a history of bilateral breast cysts. She had a mammogram and an ultrasound in March 2026. They did find that she had lumps that they thought were cancer. So she underwent a lumpectomy shortly after that, April 13th, 2026. At that time, her surgical pathology samples were taken and sent to a lab for testing. The patient healed from her surgery and was given a referral to North Bay Health for possible breast radiation or emission based on her age and the tumor specifics, and what the doctor finds appropriate at the time of her consultation. Her pathology findings are as follows. The patient's surgical pathology report came back that with her right breast lumpectomy, they found a tumor that was 22 millimeters in size. Her histologic type was a mucinous carcinoma with micropapillary features. Her overall grade was grade 2, no nodal involvement. Progesterone receptor status was positive, so her official diagnosis was mucinous carcinoma of the right breast, upper outer quadrant, PT2N0M0 G2. So my patient had her consultation with Dr. Fong. The patient had a physical examination and all findings were normal. The glue is still in place from her lumpectomy surgery. The patient was alert and oriented, no acute distress. She was tearful regarding her continuous right shoulder pain from work. She is a dental hygienist. Now worsening with surgery. The surgical scar was healed with a small scab remaining. So in her consult, Dr. Fong and the patient had a long conversation regarding her diagnosis, prognosis, and treatment options. She explained that breast radiotherapy is typically an integral part of breast conservation therapy, as radiation treatment has shown to significantly decrease the risk of local recurrence by about 2/3 and improve the overall survival of the patient. This has been shown in multiple prospective randomized studies as well as meta-analysis data. Radiotherapy is typically given to the whole breast over the course of 15 fractions. In a subset of women less than 50 years of age with favorable disease features, partial breast radiotherapy can be offered with similar local control outcomes to whole breast radiotherapy. The patient is a cautionary candidate for partial breast radiotherapy given the size of 2 to 3 centimeters. This may be preferred given the significant shoulder pain because it may be exacerbated by the positioning during the treatment. If her arms are up over her head, she may not be able to tolerate that for 15 fractions. So the risks and side effects of breast radiotherapy were discussed, including but not limited to fatigue, skin reaction, as well as the possibility for breast fibrosis, skin pigmentation changes, lymphedema, decreased range of motion in the shoulder, which she already has, rib fracture, radiation injury to the heart, lung, and the secondary malignancies were explained. The patient acknowledged an understanding of these risks and agreed to the treatment plan. The patient expressed an understanding as to their conversation described above regarding details of the diagnosis, as well as the indications, risks, and benefits of radiation therapy. She anticipates that the patient will be able to participate in the setup for daily radiation and will be able to tolerate the prescribed course of radiation therapy. All of the questions concerned and raised by the patient and the family were addressed. The patient consented to the treatment and was scheduled for a CT simulation and treatment. The Dr. Fong recommended taking pain medication prior to the CT simulation and the treatment so that her arm and her shoulder did not give her too much pain where she wouldn't be able to tolerate the treatment. She was taking gabapentin for the pain, but it was not tolerating it very well. So she was told to go to her primary care doctor and maybe ask for something stronger so that her treatment would be more tolerable. Dr. Fong said that she did think that she would be able to tolerate it, and we did work as quickly as possible in the CT sim to make sure that she wasn't in pain during her simulation. So in her simulation, I participated in this for the patient. She was alert but nervous about her treatment and showed signs of distress when we set her up for sim. She began to cry, and the therapist that I worked with was able to calm her down and show her everything that we would be doing that day. She explained thoroughly and showed a lot of empathy for her and compassion, and I think that this greatly improved the patient's experience with us at that time. And I do believe that it changed her outlook on her future treatments and her confidence that she would be able to tolerate it, because she was very worried about her shoulder pain at the time. We set her up supine with a wing board with a TMO B headrest, both of her arms up and her hands clasped on the top of her head, and a black upper back lock. We used a large knee sponge and a pad. After setting the patient up, we then wired the surgical incision, and then we called Dr. Fong, and she came and wired the breast borders. Then we proceeded to do the CT scan. Dr. Fong approved the scan that we took, and then we walked the patient to a consult room where a nurse did a teaching. And at that point, we did make her schedule for her treatment and assured her that she was, we were assured that she was okay with the times that we'd given her for her treatments, for her dosimetry and treatment. The patient's CT simulation scan went to dosimetry, where the treatment plan was created. She would be receiving accelerated partial breast irradiation treatment, 5 fractions for a total of 3,000 centigrade, 600 centigrade per fraction. She would be getting VMAT treatment with 3 arcs per treatment, going clockwise, counterclockwise, and then the arc would go back clockwise again. It did include images. This is a clockwise. This is the third arc of clockwise. So you can see her image where her ISO dose will be. And the patient showed up to treatment alert and ready for her treatment. She changed into a gown. She was placed in the treatment position on the table. She was then shifted to the treatment target. So the treatment target was oriented relative to the linear accelerator isocenter, as indicated by the treatment plan. This was accomplished by using the derived shifts from the CT origin to the coordinates of the planned isocenter. The therapist ensured that each portal, combination of gantry, collimator, and table positioning were deliverable as designed during treatment planning. The imaging was performed and compared to the reference images, the DDRs, which were generated from the planning CT scan, and a cone beam CT was approved. The patient was treated, and then she was brought down off the table and then changed into her regular clothes and was discharged home for the day. Her on-treatment visit with Dr. Fong, her OTV she was seen for her on-treatment visit. She was seen on fraction 3 out of 5. They are supposed to be seen every 5 treatments, but considering that she only had 5, we had her be seen on the 3rd treatment. She was doing well, had mild fatigue. She continued to moisturize the treatment area with calendula cream as recommended by the nurse. The patient received a radiation therapy summary. So the patient received radiotherapy for a total of 5 fractions to the right breast, 3000 centigrade total dose. She tolerated the therapy without complication. She was discharged home with instructions that the nurse would call her for a routine evaluation in 3 weeks. And the patient was to follow up with her Dr. M for endocrine therapy. And that is it. Thank you for watching.